or atrial rhythms. Now, a premature atrial contraction is a beat that occurs earlier than expected, and it comes from outside of the SA node. This is typically caused by a small area of tissue that's more irritable compared to the rest of the atrial tissue that eventually causes it to fire early, which results in this early contraction of the heart. A PAC is usually not clinically significant, meaning it doesn't cause symptoms and it's very tolerable for someone. But if they are very frequent, we can see symptoms such as hypotension, dizziness, lightheadedness, and nausea. The characteristics of a PAC are that the P wave and the PR interval are going to be different. And this is because the wave of depolarization is moving in a different direction compared to normal conduction. So the morphology of the P wave in a PAC depends on where at in the atria the impulse originated, and our PR interval can be shorter or longer because of the same process. If the impulse has to travel further to get to the AV node, that's going to represent as a elongated PR interval, and vice versa if it's close to the AV node. So I can isolate my PAC here, and this is the same beat, just looking at it from two different leads here. Not sure what leads these are, but that's our PAC. You can very clearly see that that's what looks like a sinus beat. It's just at the wrong time, and it makes this rhythm that we're looking at regularly irregular. Now, after the PAC, after the P wave and the PR interval, the rest of conduction through the heart should be normal unless there's some sort of pre-existing block later down the line, such as a right bundle branch block. Whenever we have a premature contraction like a PAC, a premature jugular contraction, or a premature ventricular contraction, it can cause two types of things, either a compensatory or a non-compensatory pause. Now, a non-compensatory pause is what we most often see with a PAC, and in a non-compensatory pause, the SA node is reset, meaning that the rhythm that occurs after the SA node is occurring at a different beats per minute in regularity compared to the rhythm previous to the premature atrial contraction. So if we were to march out the P to P intervals before and after the premature atrial contraction, we would see that they don't line up. Now, in a compensatory pause, the SA node is not reset and it continues to fire at its normal pace, so the P to P intervals would march out and match up. That's most commonly seen with a PJC and a premature ventricular contraction, but you can have it either way between those contractions. In some cases, a PAC can be difficult to spot, and that's because it can occur at any point in the ECG rhythm. So look for some subtle clues, like a P wave that is occurring on the T wave, like you see here. So just like in a tachycardia, sometimes we can see the P wave imposed into the preceding T wave, creating this camel hump appearance. So look for things like that. In this rhythm above here, you can see pretty clearly that it's a regular rhythm, but it's also irregular. So it's regularly irregular. Anytime we have that type of rhythm, we want to investigate what's causing it to be irregular. Is it a premature contraction, or is it meet some other diagnostic criteria for another rhythm? Now, in some cases, the AV node can block the premature atrial contraction, so you may see just a P wave that doesn't belong with no preceding QRS complex. The problem with that is that if that occurs very often, that's going to decrease cardiac output and decrease blood flow leaving the heart, and that could result in a hemodynamic compromise for our patients. The first rhythm we're going to look at is an ectopic atrial rhythm. In this rhythm, it's quite simply put, it's just an ectopic focus in the atria that takes over as the heart's pacemaker. For it to be an ectopic atrial rhythm, the heart rate should be less than 100, and the PR interval should be normal or slightly prolonged. This type of rhythm is usually not life-threatening because the heart rate's not affected as much by this, but it can also be very difficult to pick out and diagnose because the differences between a sinus P wave and an ectopic P wave are actually pretty minimal. And in any case, having access to previous EKGs to compare P wave morphology is the gold standard in being able to diagnose ectopic atrial rhythms. If you have an inverted P wave, in leads 2, 3, and AVF, that actually makes this a little bit easier to call it an ectopic rhythm, because your inverted P waves in 2, 3, and AVF really have two different causes. The first cause is if your PR interval is normal or slightly prolonged, then it could be likely that the ectopic focus is just very close to the AV node, so the vector of electricity that it takes towards the AV node creates the inverted P wave. Or the other cause could be that the P wave, inverted P wave, is being conducted retrogradely from the AV node. That would be considered a junctional rhythm, which we'll talk about in the next module. So if you look at the PR interval and you find that it's short, less than 0.12 seconds, it's likely that that complex originated in the AV node and not an ectopic atrial location. And this is really just because the AV node does not do well with retrograde conduction. So if the impulse happens in the AV node, it's just immediately going to send it backwards into the atria, and you get a very short PR interval with an inverted P wave. So before we talk about focal atrial tachycardia, let's interpret the rhythm on your screen here. I can tell just from looking at it that it actually looks like it's slightly fast. So this one looks like it lines up. So 300, 150, 100. So I'm right at about 100 beats per minute, maybe slightly higher than that. It does look regular. So I have a regular rhythm at 100 beats per minute. So I'm dealing with some sort of tachycardia. I'm then going to look at the P waves, and I can see that I do have a P wave for every QRS. Next, I'm going to look at the morphology of the P waves, and I can see that all of the P waves look the same, but they're inverted. And I know that in lead 2, they should be upright. So I have inverted P waves. They all look the same. Okay, let's keep moving. Next is my PR interval. Well, very clearly, just from first glance, you can see that this is looks like a short PR interval. I'm gonna zoom in. It's hard to see because there's nothing here, but yeah, we're probably dealing with about right at 4 boxes, so it's barely in normal limits. So my PR interval here is 0.12 seconds. Is my QRS narrow or wide? Well, it looks narrow from here, so I have a narrow QRS complex. And lastly, I've already talked about it, I have a 1-to-1 P to QRS ratio. This rhythm would be considered an ectopic atrial rhythm because those P waves are inverted. The PR interval is considered normal, and I have a 1-to-1 P to QRS ratio. So I would have enough to say that this is likely an ectopic atrial tachycardia. Now, you can have some focal atrial tachycardias that have a irregular rhythm, and that's because the AV node is trying to protect the heart, because that's its job, is to have that delay and be kind of cardiac protective over there. So it can change the P to QRS ratio if it blocks some of those rapid impulses coming into the AV node. But generally for focal atrial tachycardia, you should see the ectopic P waves, a 1-to-1 P to QRS ratio, and you should have normal PR intervals. Two main causes for this type of rhythm could be some sort of re-entry pathway in the heart, or just an increased automaticity of this ectopic site. Those are the two common causes there. This type of rhythm actually accounts for about 5 to 15% of our regular and narrow supraventricular tachycardias. This slide is similar to what I talked about on the last slide, where the AV node blocks some of the impulses in a focal atrial tachycardia. We almost exclusively see that in patients with digoxin toxicity, which is a cardiac medication that can cause various types of arrhythmias. The AV block in this case, like I said, is a protective mechanism to block some of the atrial impulses so that the ventricles have time to fill. Now, we typically are going to see a focal atrial tachycardia with an associated AV block when the atrial tachycardia gets to rates between 150 and 250, so that's pretty fast. And we can see a return to baseline between ectopic P waves. Now, we can have a second or third degree AV block here that creates a different atrial and ventricular rate. So we're going to talk about AV blocks more in depth in the next module, and then likely we'll come back to these types of rhythms as we practice. Wandering atrial pacemaker is one of our irregular rhythms. And it's created when you have 3 or more different ectopic focuses firing at their own rate in the heart. To be considered WAP, the rate should be less than 100, and you cannot identify any underlying regular rhythms. So the rhythm's just completely irregular. And we would find that by marching out our P to P intervals and our R to R intervals. So you can see here in the EKG above, if you get to the point where you're looking at the P waves, you can see that, okay, some of them, they do look different. These look similar, but this one's more humped and not pointed, and this one's upright like this one. So just by looking at this, you can say, hey, this is an irregular rhythm, and I have different morphology of my P waves. So this must be wandering atrial pacemaker. A multifocal atrial tachycardia is the same as wandering atrial pacemaker, except the rate has to be over 100 beats per minute. So you still have 3 or more ectopic focuses in the atria that are acting as the pacemaker, creating a completely irregular rhythm. So you can see here that we do have this criteria with more than 3 different P wave morphologies, and you can see varying PR intervals from beat to beat to beat. We haven't talked a lot about fusion complexes. Basically what that is the ectopic impulse is just more likely to fall during the refractory period of the heart, and that can lead to a fusion complex where you have the beginnings of a normal looking P wave PR interval and then this really wide, bizarre looking QRS complex. That would be considered a fusion beat, where the ectopic beat is then fused with another ectopic focus, creating a fusion complexes of both independent beats. This multifocal atrial tachycardia is commonly found in elderly patients and also those with respiratory conditions like COPD. Some of the drugs that we give, like albuterol, do have an effect on the heart. So albuterol is a sympathomimetic drug, so it can increase heart rate a little bit. So if you have a patient that may have irritable atrial tissue and we're treating that with lots of albuterol, that can cause this rhythm to develop. So moral of the story, when you're administering medications to elderly patients with respiratory conditions and you're administering 2-3 doses of albuterol, it's best practice to have that patient on the monitor and monitor their rhythm from there. Atrial flutter is characterized by very rapid atrial rates, between 250 to 350 beats per minute. And it's important to understand that in an atrial flutter rate, there is no isoelectric segments separating the P waves or the EC or the QRS complexes. So what this looks like, it looks like a sawtooth pattern, like the teeth on a saw, that's intermittently broken up by QRS complexes. And we call those sawtooth P waves F waves or flutter waves. So if we were to look at an EKG of atrial flutter, we would see these flutter waves that look just like this. Looks like sawtooths, right? Each one of those is an atrial contraction. If you were to take the QRS complexes away from an atrial flutter rhythm, you would just see this P wave conduction the entire time and no QRS complexes. The reason the QRS complexes are kind of intermittently placed is because the AV node is trying to protect the ventricles. So it's keeping the ventricular rate slower than the atrial rate in most cases. So we would see a rhythm that might look like this. Right, with variable conduction, but you can see there's no isoelectric segments. You can see the flutter waves, and it's broken up by the QRS complexes as the AV node lets one of those impulses through, and we see the ventricular depolarization because it's stronger than the atrial depolarization that is occurring. Now, an atrial flutter rhythm is caused by a re-entry pathway, most commonly found in the right atrium, that basically sends the impulse back around to an area of the heart that was already depolarized and is ready to respond again. And it creates this perpetuating circle of the impulse just re-entering over and over and over again. And that's a common pathway that leads to tachycardias. So a re-entry pathway can be caused by having two types of tissue with different characteristics. So you can see here we have basically a circle. Imagine that this is a roundabout or a road that has two exits. And we have one pathway here on the right that has a fast pathway, meaning it's a nice open road. It's a dirt road. You can drive it very fast. But because it's full of dirt, it's going to kick up a lot of dust and sand, which means it's going to take it longer for the next car to be able to drive down that pathway, right? So that's one characteristic. It's a fast pathway, but it takes it longer to reset for the next car or impulse to drive down the road. The other tissue characteristic we see is an area that has a slow pathway. So imagine this pathway is full of rocks and potholes, and it's also very wet ground that you just have to kind of slowly weave your way through to get down that area of road. But because it doesn't have any dust, it has a short refractory period, so it's able to reset very quickly. So a re-entry circuit, normally what happens 99% of the time is on the left of our screen here, we have an impulse. In this case, I'm going to draw just a little green square. Imagine that's a car, right? So the impulse is initiated and it's sent down the conduction pathway, and it's going to get to the crossroads here, and it's actually just going to split in two. So some of this impulse is going to travel around the fast pathway, and the other bit of it is then going to move around and go into the slow pathway. And because the fast pathway is faster, this impulse is going to make its way around, and then once it gets here, it's going to splint and it's going to send its impulse down. So imagine that is the atrial impulse that goes through that accessory pathway, it hits the fast pathway, boom, it makes its way to the AV node. The AV node sends it on through from there. Well, it splits to the right here, but then it's going to keep coming around. And what's going to happen is, as it's coming around, this pathway is just now getting out of the slow pathway, and boom, we have a collision of those impulses. And what that does is that cancels out the impulse, right? So it cancels it out, and it stops the impulse completely, so that when the next car comes along the line, so car number 2 comes along the line, there's no impulses left, and it does the exact same thing. That's what happens 99% of the time. So for a re-entry circuit to set up, we have a normal beat that occurs. So that's this green car right here in the middle. So we have a normal beat that comes in. Same thing that we just talked about happens. The impulse travels around, it splits. As this impulse moves through the slow conduction, right, it cancels out right here in the middle. Now remember, because these pathways have different characteristics, this fast pathway has a long refractory period. So there's a bunch of dust particles all up in the air here. And so this area of the accessory pathway is not repolarized yet. But this short period, because it has a very short refractory period, there's no dust. So it's ready to respond to another impulse. And what we see happen in a re-entry circuit, erase this here. What we see happen in a re-entry circuit is most often caused by a premature contraction. So this normal beat happens, and then here's a premature contraction coming from the atrium, right, that comes up, and it's going to get to this point, and it's going to do the same thing. It's going to split and go this way and that way, but because this tissue right here in the fast pathway is still refractory, the car is going to come up to here and it can't go anywhere. So that impulse is effectively blocked. It doesn't travel through the rest of the pathway anymore. It's now blocked. And what we see is this car goes this way through the slow pathway, and it's able to keep traveling through the slow pathway, but wait, this car never made it around to block that impulse. So that premature beat is able to come around this way and bam, send up there. By the time it gets to here, this area of the fast pathway is actually already repolarized. So that car is able to go through. And then what we see happen is it makes its way back around, and it splits off this way, and it continues to go back this way. And we have this re-entry circuit where it just keeps going around and around, leading to a tachycardia. In this case, this would lead to an atrial tachycardia, which for us is atrial flutter when we see those sawtooth waves. Right? Each one of those P waves that we're looking at is caused by this re-entry pathway that we're looking at here. So let's put our ECG skills to the test and interpret this rhythm here. Well, to start, I'm looking, is it fast or is it slow? It actually looks a little bit fast. So with a 12 lead here, this is going to be a 6-second strip. I'm going to count about 15 QRS complexes. So, I mean, my rate is roughly 150 beats per minute. But when we ask ourselves number 2, what's the regularity, we can see that it's completely irregular. And in that case, that makes my heart rate variable. And that makes sense because when I look at the distance in the RDR interval from here to here compared to here, right, it's much longer here and much shorter here. So that would mean I have a variable heart rate that's completely irregular. Right, the third thing I'm asking is I'm looking for P waves. And in lead 2, which is the best lead to look for P waves, they should always be upright and should be preceding the QRS complex. And I don't see that here. I actually see what I would refer to as our flutter waves that we just learned about. And those flutter waves are significant for atrial flutter. So that's what's already coming up into my mind. Next, I'm going to keep going. Do I have a PR interval? I do not. So that PR interval is absent. So it's not applicable here. My QRS complexes, they look narrow. All right, and then my P to QRS ratio. And this is where with atrial flutter, if you were to have a 1-to-1 ratio, your patient's going to be in some serious trouble. In this case, we can see that this would be considered a variable P to QRS ratio. And that's because when I look here, I have 1, 2, it's like I probably have a 3-to-1 ratio there. And then in this beat next over here, this is likely a 2-to-1 conduction. So 3-to-1 and a 2-to-1 is what I'm looking at. So I would have enough to call this atrial flutter because it's completely irregular. I can see the flutter waves. I have no PR interval, and I can tell that I also have a variable P-QRS ratio. So in atrial flutter, you can have a consistent conduction through the AV node where it's a 2-to-1 conduction, 3-to-1, and even a 4-to-1. And that's really just the physiological block by the AV node that's helping to keep the ventricular response under control. You can imagine if this was a 1-to-1 conduction ratio, you would have a ventricular response that's 250 to 350, and that's just not tolerable for us. You can also see a wide QRS complex. If you have a patient that has a pre-existing heart disease or bundle branch block present, that's still going to show up on your EKG and can make the whole rhythm be a little more difficult to interpret. What we saw on the previous screen was atrial flutter with a variable conduction where it switches back and forth, and that's just the way the AV node is sending those impulses. The last and one of the most common rhythms that we see in the field is atrial fibrillation. And this is a completely irregular rhythm that's characterized by the absence of any observable P waves. So you can see on the EKG here where I have underlined fibrillatory waves that look almost like you would see with ventricular fibrillation. They're just occurring in between QRS complexes. In atrial fibrillation, the ventricular response is variable, and that is because the AV node is essentially triaging which impulse it's going to let through the AV node, and then it's blocking the rest. So those fibrillation waves in AFib are created by just multiple different ectopic impulses all competing for each other in the atrium at the same time. There's really 3 different types of atrial fibrillation. There's paroxysmal, which would be an acute exacerbation that just results in sudden hemodynamic compromise or sudden symptoms like shortness of breath, pulmonary edema, lightheadedness, palpitations, and syncope. In these types of cases, treatment is likely to subside the symptoms and the patient may be okay. Paroxysmal is another way of saying it can be fairly short-lived. Persistent atrial fibrillation would be one of the chronic forms of AFib, where the rhythm can still be converted to a sinus rhythm with medication or cardioversion in the field. And then we have permanent atrial fibrillation, which is the patient is in its chronic stable form, where the patient always has AFib. It's just controlled via rate. So regardless of the three different types of AFib here, all of them can present with a paroxysmal exacerbation and lead to hemodynamic compromise. And that's likely because the ventricular response becomes too high, right? The heart rate becomes too high because the AV node's letting too many impulses through. So for pre-hospital providers, our management of atrial fibrillation is aimed at rate control and not rhythm conversion. We're just trying to lower the heart rate down so that the patient can still get a good cardiac cycle with filling of the ventricles and a diastole period to maintain cardiac output. Thank you guys for watching. Please like and subscribe to my YouTube channel, The EMS Edge.